When I was invited to do this, I said, do I really want to go over the data? The answer was no. Do I want to revisit things that everybody knows about? The answer was no. So I thought what I would do is give you a perspective with a little bit of editorial comment and then engage in a conversation. Because I think that's, when we're sitting around peers, that's what we really need to think about. So I'm taking the position of where are we, whatever today is. May Day, Cinco de Mayo 2018. So I'm not going to talk about where we're going to be with some of Mario's data in the future, although we should talk about it and engage in it, but just where are we today? So when we think about TKIs, this is what we think about. We think about dosing, we think about adverse event management, and we think about treatment duration, something called optimum efficacy. So what used to take an hour to talk about each trial, now in 12 years takes about 1 minute to talk about 12 years worth of trials. And that's listed on this slide. So what's important? Well, since 2006, we've approved a boatload of targeted agents built on the back of Bill Kalin's observation from decades ago. So that's quite an accomplishment. The trials have primarily been done from the perspective of the pharma sponsor, not always the ideal comparator, not always the ideal patient population, but we do know some recurrent themes. What are the recurrent themes? We're better than placebo. We're better than bad TKIs. As the second and third generation TKIs got better, we got incrementally a little bit better in terms of our endpoints. Not dramatically better, but incrementally better. And as we added not just dirty molecules, but dirty molecules that seem to attack biology, MET, AXL, RET, we now have a paradigm shift, and FGF, we have a paradigm shift to where most of us think that we have a pretty good handle on how a TKI is going to work in the setting of at least clear cell RCC. So then the question becomes, how do you take this over a decade's worth of thousands of patients and integrate it into our practice, especially with we're 1 month into the new FDA approval of Ipi/Nivo. So this is the way I do it. And this is my next to the last slide. The next is really posing questions. But this is the way I think. I've stopped calling it first line, second line, and third line. I think that was fine in the 90s and the 2000s. And I think that most of us would agree that most of our kidney cancer patients are on a journey. And that journey changes over time dependent upon where they are, how they react, what's left behind, how we're using and integrating clinical trials. So I won't talk about adjuvant therapy, although I'm happy to do so if you want. And I want to talk about metastatic disease, at metastatic disease progression, and then beyond. So this is the way I think the data lines up. And this is quite independent of how the FDA chooses to issue the package insert, because the trials are done in certain populations, and then the package insert and the indications are always often very different. So I think in IMDC or MSKCC good risk patients, I think we're still left with a TKI, pazopanib or sunitinib. I think the data from Ipi/Nivo, even though it's not perfect, with that really over 50% objective response rate to sunitinib in good prognosis patients, is a further reiteration of that. I think in intermediate and poor risk patients, we have Cabo and Ipi/Nivo, and I think we'll engage in a conversation about whether or not Cabo or Ipi/Nivo should be chosen. We're clearly not going to see a randomized trial that compares those two. There's no incentive by either of those companies to help us figure out which is better. So we'll be left with cross-trial comparisons and the use of that as we see fit. I think there's also clear evidence that there's a population of patients, as Jim talked about, that we could observe, and we often do that more so now than we've ever done in the past, and then we integrate clinical trials. And then when you get to metastatic disease progression, you're left with a grab bag of agents that have been tested in the frontline setting, never been tested in the post-cabo, post-IO-IO combination, which you're left to use. I know that Mario talked about, or somebody talked about, use of IO targeted agents post-IO-IO. Maybe, but we'd have to wait to see if there's actually data that can support that. Axitinib, cabo, lenvatinib, everolimus, nivo. I reserve everolimus for NGS patients that I think demonstrate reasons to use an mTOR inhibitor in a patient that has some abnormality of that pathway, and obviously clinical trials. So that's my current May 2018 paradigm. So what are the issues? The issues are there patients in whom frontline therapy with the TKI is preferred? Patient populations, comorbidities, agents, sites of disease. If frontline therapy is an IO-IO combination, what's the preferred next available therapy? Again, patient populations, comorbidities. Is there any evidence that response to prior therapies dictates how you will do in second-line therapy? In my view, the answer is no. Which agents, sites of disease? The converse is if a frontline therapy is not an IO-targeted agent combination, is an IO-targeted agent combination. Now looking into the future, what's the preferred next line therapy? Should it be IO-TKI, IO-BEV? Some thoughts about that. And lastly, what I tried to introduce with Hans' lovely talk is we continue to focus in kidney cancer on regulatorily approvable endpoints that may or may not have any relationship to what we need to do for patients. And yes, PFS and ORR are reasonably easy to measure. Great. Is that really what our patient wants? Patients walk into the office and say, doctor, I'd like to have progression-free survival benefits. Generally not. Do our patients really talk about objective response rates? Generally not. What they want is longer survival with reasonable toxicity in the face of their comorbid diseases. So that's where I think we are in 2018, and we can enter into a bit of a conversation about how each of you pick the populations of patients that you would choose to use a TKI. That's it.
So as we look at it, I thought that was a great setup. What about again when we look at IO and TKI, we combine them, but is truly combining better than sequence or sequence in a rational way? We saw the biology of why we may want to do it, but I mean, again, should we be thinking more about how the cancer adapts to any therapy we do, and then as we sequence them, then target the drugs that would most likely be sensitive after that? So in other words, the cell has to have a way that it's going to try to survive. Should we target those survival pathways after, and when we start thinking about this sequencing? So what's your thoughts?
Yeah, so I will give you my editorial comment about that. I mean, the good and the bad of kidney cancer over the last 10 plus years has been for a rare tumor to get investments by big pharma to ask and answer questions. Because prior to middle of the 2000s, nobody was interested in kidney cancer. So we have to take the good with the bad. And we're still with the good and the bad, because most of the questions that are being asked, in my view, are being driven by FDA regulatory approvals, not necessarily how best to manage the journey. What we hope is that by seeing the results of the data that's coming out over the course of time, we will be able to interpret how to influence the patient's journey with kidney cancer. For example, if it turns out that an IO targeted agent combination produces CRs or major responses that are something that we've not seen before, I think that's an influencer. If, on the other hand, there's really still less than 5% CRs, an improvement in PFS, an improvement in ORR, then I don't think we ever get at the answer of maybe it's just the sequence that we should be offering as opposed to the upfront. And I think for all of us that have managed kidney cancer over the years, there's been a dramatic change in how our patients do and who we see in the clinic. No question about that. So we've accomplished that, but we've really not gotten down to asking questions that are relative to the overall management of the patient as opposed to how to get things approved. All due respect. And please push back against that if you feel like you need to, especially those at the back of the room.
Bob, question.
These are.
If you had all the resources in the world and all the patients are available interested to participate in trials, and you were asked design the trial or trials that in 2018 you would like to propose and ask us to join you, what would that trial or trials be?
Yeah, so I think let's take Ipi-Nivo. I think Mario should tell us, based upon, maybe it's not today, maybe it's tomorrow sometime, Mario should tell us which is the best IO targeted agent combination that we want to take forward, and I'd compare it head-to-head with IO-IO. Pretty simple. Secondly, I would say, rather than using Sutent as the control arm for many of the combinations, which always leaves open, why are you using yesterday's best generation TKI when we think there's a better generation TKI? I'd say, have the stamina to ask combinations against Cabo or agents that are like Cabo that are now better, at least in prospective trials, than historically than Sutent and Paz. So I think oftentimes, and we know this, I mean, I'm not telling you anything you don't know. We've talked about this for 100 years. When you do a trial and you're a company, you want the comparator to be someone that you can win against. So you pick the best one available to you that gives you the best advantage, and the regulatory body will approve it. And then you send your marketing team out there to try and sell it. But that doesn't necessarily translate to the best design of a trial. So I would like to see IO combinations compared to IO other combinations and start to look at them head-to-head. They could be non-inferiority, they could be superiority, but they should be something so that we can compare them so we're not just left with a half a dozen trials that combine IOs with no cross-trial comparisons.
Bob, just a couple of things. I mean, it's really complicated. I'm not sure that because Cabo is better than Sutent in randomized trials as single agents that's necessarily going to be the case when they could combine with Nivo, because they have different biological properties. Cabo inhibits MERTK and AXL, so it's MET in some cases, and that might be some of the reason why it's better. But they may have different effects on MDSCs, Tregs, other biological characteristics. The only thing they share is the VEGF receptor inhibition. So I think those answers are going to be a little bit more nuanced than that. And one of the problems with the VEGF receptor IO combinations is that you get scared to death to take them off, so you never discontinue. So with IO-IO combinations, I do stop therapies, when I get them to a certain point. With VEGF receptor combinations, I never take them off those therapies. I keep them on forever. Maybe you can, and there's a few patients that, interestingly enough, have gone off because they came in for other medical problems, had to stop the therapies, and then I watch them for 3 months and their disease didn't come back. So it is possible that you can discontinue those therapies,
Sure.
But we don't know that yet.
Yeah, I think the other thing, and I agree with all of that. That's why these kind of conferences are so wonderful. I mean, we heard, and I'm sure we'll talk about this yesterday. So when Drew presented at AACR, the observation in lung cancer that a couple cycles of Nivo prior to surgical resection for stage 1 and 3A resectable lung cancer produced 50% CRs. And we heard yesterday that something similar is occurring in bladder. And we know that something similar to that is trying to be reproduced in in kidney. I think while we still take care of metastatic disease, I think the efforts are to move it earlier and earlier and see what exactly is coming out of that, and we'll just have to wait and see.
Great.